Hi everyone, Dr. Saurabh here again. So now I will take in this video, audio, whatever you call, the eyelids and lacrimal apparatus. So the first quiz of 8 questions was on eyelid anatomy and applied aspect, in which the first question I asked was sim-blephron. Now sim-blephron, blephron means eyelids, and sim means additions. All the four options has additions. Now, this is addition between the two conjunctiva, that is bulbar and palpebral conjunctiva, can be seen in severe dry eye conditions like keratoconjunctiva sicca, chemical injuries, Steven-Johnson syndrome, pemphigoid. Ankyloblephron is addition between the upper and the lower eyelid. Now, Madarosis one-liner is loss of eyelashes, can be seen in hypothyroidism. Leprosy is the answer here. Vitiligo and Vogt-Yang-Harada has poliosis, that is whitening of or graying of eyelashes. Extra layer of eyelash is distichiasis, in which the extra layer comes from the posterior margin of the eyelid aspect as well. Now from posterior margin only meibomian gland comes. So this is meibomian gland is converting into hair follicle. So sebaceous convert to pilosebaceous, that is nothing but metaplasia of meibomian gland. Now it's a lateral view of the eyelid in which B is orbicular is oculi muscle, E is levator palpebrae superioris muscle, C is the tendon of LPS known as aponeurosis, D is the molar muscle, that is upper tarsal muscle, A is the continuation of periosteum to tarsus, that is orbital septum. In Bell's palsy, like seventh palsy, the muscle which is supplied by seventh nerve is orbicularis. So B is the answer, which leads to lag of thalamus, which is inability of the eye to close in primary position. Now, in primary gaze, the distance of the upper eyelid margin and the reflex in the cornea, which is in the center, is known as marginal reflex distance 1. MRD2 is distance of the corneal reflex to lower eyelid margin. MRD1 plus MRD2 is vertical palpebral fissure. Now, I told you this is lag of thalamus. I know many people must have answered lid lag sign. The lid lag sign is when the when the eyelid lags the eyeball in down gaze, that is lid lag sign, can be seen in thyroid eye disease, can be seen in congenital ptosis. Now corneal diameter is 12. The vertical palpebral fissure means the distance of upper and the lower eyelid. Now we should know 1/6 of the cornea is covered with the upper eyelid, so 2 mm is already covered, left is 10 mm. Here MRD1 value will be 4, MRD2 will be 6. Now which is false for eyelid margin? The posterior margin is sharp, anterior is rounded, true, both are true. Puncta is present in the medial side, that is easy one, true. Now upper puncta, lower puncta are not in the same line, upper is slightly nasal. Now it's a fact. You know, if you know, you know, if you don't know, you don't know. That is the answer of this question. Alright, so that was a quiz on eyelid anatomy. Now let's go to the quiz on ptosis. Alright, I'm ready to give the test on ptosis. The first question on ptosis means drooping of the upper lid in primary gaze. Now the first question is Horner syndrome. Now this is a NEET exam repeat question. Horner syndrome affects the sympathetic supply, and molar muscle is supplied by sympathetic stimulation, that is upper tarsal muscle, which is normal, causing elevation of the upper lid by 1 to 2 mm. So there is a partial ptosis in Horner syndrome due to molar muscle, and the surgery of ptosis in Horner syndrome is mullarectomy, that is Fasanella servat operation. Now this I told you already, inability of the eyelid to follow eyeball in down gaze is known as lid lag sign, that is seen in congenital simple ptosis and thyroid eye disease. Congenital ptosis, there is maldevelopment of LPS muscle. So eyelid crease is due to LPS muscle, so there is weak or absence eyelid crease, true. B I told you is true. Poor function of molar is not related, and lid lag sign I have told you already. Now corneal diameter is 12 means upper eyelid is covering 2 mm of the cornea. Vertical palpebral fissure is upper eyelid covers 7 mm of the cornea. Means upper eyelid covers 7 means 2 is already covered. So extra 5 mm is covered. That is the extra 5 mm is ptosis. That comes in severe grade of ptosis. Now this is also I told you already. Aponeurotic ptosis is senile ptosis or traumatic ptosis affecting the LPS muscle aponeurosis. That is C option. It is the most common cause of ptosis. And aponeurotic repair has to be done. The problem is in insertion of the LPS muscle. All are true. It's a complicated congenital ptosis. When we move your jaw, that is lateral pterygoids, the fifth nerve takes the impulse. Abnormal fifth nerve takes impulse to LPS, causing winking of the eyelid due to LPS insertion. Means fifth nerve takes the abnormal innervation from lateral pterygoids to LPS. Seventh nerve is not involved in this. Levator disinsertion and sling is done. That is true. Now this is what eyelid. Something is joining the eyelid to eyebrow. So in eyebrow there is frontalis muscle, which is, and this is the sling which is mechanically elevating the eyelid in severe ptosis. So this is frontalis sling operation, and this material is facial lata. I told you this honor story. This is a mullerectomy, that is Fasenlana servata operation. So that's 8 questions on ptosis. The next one will be tear film. There are 3 layers of tear film. Outside is lipid, middle is aqueous, innermost is mucin, which is in contact with the cornea. The first question is, Shermer test evaluates the aqueous secretion. That is a fact, and that's the answer. Decreased Shermer values are seen in dry eyes, like any keratoconjunctiva sicca is dry eyes. Chemical injury causes dry eyes. Sjogren's syndrome causes dry eyes. But if there is a blockage of puncta, there is more watering. It will cause increased watering, not dry eyes. Normal value of Shermer test is you have to wait for 5 minutes. Normal value is more than 15. Severe dry eyes is less than 5. Now, which of the gland does not provide the basal secretion? Basal aqueous secretion is where 3 accessory lacrimal glands, that is Wolfram, Crossmall. The main lacrimal gland gives a reflex secretion. If something goes inside your eye, you have more watering, that is due to lacrimal gland. And in the class I tell you about the HOD and 3 residents. Now tear breakup time is what? You ask the patient to sit on slit lamp, you put fluorescent dye, you see under cobalt blue filter on slit lamp, and you ask the patient not to blink, or you hold his eyelids and you note down the time after how much time the dry spot is covering. Dry spot is coming, so more value after more time. If the dry spot is coming, it is a good thing, means it is tear film adequate. So more than 10 seconds is normal, less than 10 seconds is abnormal, and this tear breakup is mostly because of mucin component of tear film. So red filter is not required. Chalazion is lipokeratomatous inflammation of meibomian gland. So A and D are true. More common in upper eyelid because meibomian glands are taller and larger in the upper eyelid, and it affects the posterior or inner eyelid. It is a painless swelling of the inner eyelid because meibomian gland is present in the posterior aspect of the eyelid. For small chalazion, intralesional steroid is given, and for large chalazion, incision and curettage. And it is a sebaceous cell. Meibomian gland is a sebaceous cell. That's why recurrent chalazion gives suspicion of sebaceous cell carcinoma. That's why most common site of sebaceous cell carcinoma is an upper eyelid. Now there is blood. Blood ocular barrier is not because of tear film. Rest are true statement. That's a straight away question, and I asked the question previously also in previous quizzes. A slightly tricky question. It will help you to know that you should read the questions properly. Bitter spot is seen in 8 months old. Directly the B option is wrong because vitamin C is not the answer. Vitamin A is the answer. It is 1 lakh years, but vitamin A, that's the answer. More common in temporal, yes, because goblet cells are more common in nasal bulbar conjunctiva, which requires vitamin A. Assurance to parents that vision is not affected, true, and it's X1B stage of WHO classification. So 6 months to 1 year, 1 lakh international unit is given. And this question, the sequence of staining of dry eyes, I don't know the answer. Good if you mark this. Which of the following is false for the layer of tear film in contact with air, that is lipid? And I told you already, lipid is not responsible for tear breakup time. Mucin is responsible. Zey's, meibomian, and hair follicle are contributing to that. That is sebaceous gland. That's the 10 questions on tear film. Now the last one, let us come to lacrimal apparatus. Okay, so lacrimal apparatus means all the glands which are producing tear film and the anatomy which takes tears into the nose. Now, lacrimal gland is of course involved. Canalicula's from puncta, canalicula's, common canalicula's, lacrimal sac, nasolacrimal duct, and open into inferior meatus of the nose. Now, why will levator muscle? Levator muscle divides the lacrimal gland into upper and the lower eyelid. That does not mean it is involved in lacrimal apparatus. Orbicularis muscle closes the eyes and it is involved in lacrimal pump mechanism. So that is involved in the lacrimal apparatus, not levator muscle. Orbicularis creates a suction which takes the impulse of the tears from the lateral to the medial side into the punctum. And all are tests for watering. Jones test, tear breakup time. I already told you in this audio video that is for dry eyes, not for watering eyes. But dacryo means, see, dacryo word is related to lacrimal sac and gland. If there is a cyst involved with that, that will be lacrimal sac. So you put a dye into canalicula's. It tells about the anatomy of the lacrimal apparatus. It's of no use in lacrimal pump failure, that is true, and it cannot be done in puncta occlusion. Now, a lipoidal dye is um, placed in canalicula's. That is actually okay. So that is also a true statement. I have changed this. I've given the answer this only, but this is also true statement. I have edited this already. All are true statements over here. The change which I have done is lipoidal dye is just put into conjunctival sac. That is wrong. It is directly injected into the canalicula's. That is true. So this question, just ignore it if you have done previously, or else I have edited this question already. Now, regurgitation test means you press onto the lacrimal sac area and you see whether the mucus is coming out or not of the puncta. So it's not done in acute dacryocystitis because the patient is having pain, swelling. It is done only in chronic dacryocystitis when there is a NLD obstruction. There is a fluid in the sac which converts to mucus and that can come out. So it is not done in acute. Of course, I mean, in acute dacryocystitis there is mucus and it can come out, but you can't do this. That's why chronic dacryocystitis is the answer over here. That is chronic NLD obstruction. Now, Jones test 1 means you put a dye over the eye and wait for 5 minutes to see whether the dye is coming into the nose or not. Now, if the dye is not coming, that is Jones test 1 negative. You flush with saline and see whether the saline and dye are coming or not. Now, if there is a partial NLD obstruction, you can break the obstruction with the saline force, which is directly into canalicula's. So, saline dye both will come. Both will come in partial NLD obstruction. In complete NLD obstruction, neither saline nor dye will come. Pump means orbicularis is not functioning. Means the dye is not able to suck into the system because the pump is not functioning. But in Jones test 2, you are putting the saline directly into canalicula's. So only saline will come. The dye is not able to suck into the system. That's why C is the answer over here. In puncta obstruction, you can't, nothing will come, of course. But in pump failure, the dye is not able to suck into the system and saline is given directly into canalicula's. So only saline will come. I told you already in this audio video that lacrimal gland is dacryo. Lacrimal sac is also dacryo with cyst. So dacryocystitis is inflammation, infection of the lacrimal sac, while adenitis is inflammation of the lacrimal gland. Now, if you put a syringing from lower puncta, regurg was seen to come from the opposite puncta. Means there can be obstruction in the common canaliculus, NLD obstruction,
In NLD obstruction, regurg material will be slightly turbid because some mucus will be there in the sac. Whereas common canaliculus, there will be clear fluid come. No, it's not possible in upper canalicular obstruction, and you can't do this test in punctal arteries. That is true. So C is the wrong answer because in upper canalicular obstruction, if you put the syringe in the upper puncta only, then it will come from the same puncta. And in lower puncta, if you put it directly, it will come to the nose. No benefit. So DCR means you make an opening between the lacrimal sac and the middle meatus of the nose. The option is correct. In the medial wall of the orbit, M and L, maxillary and lacrimal bones are manipulated. That is C is correct. It cannot be done in acute active cystitis. That is the answer. Even if you don't know what is thumb syndrome, if the obstruction is very small, there is accumulation of the fluid inside that residual area. Even if you don't know, you're not expected to know this, but still, I've given you because you should know that it cannot be done in acute active cystitis, and it cannot be done in fibrosed lacrimal sac. Can be done in lacrimal gland tumors, fibrous lacrimal sac like TB, sarcoid, syphilis, and acute dactylocystitis I've given already. It can be done for chronic dactylocystitis, dacryolyth, mucocele also it can be done. That's the 9 questions of lacrimal sac. One question I've edited already. You can check afterwards. Best wishes.